Hello, everybody. Welcome to today's ATI seminar. My name is Michael Khoury. I'm a pediatric cardiologist in advanced heart function and transplant here at the University of Alberta. And I have the great pleasure of introducing Dr. Catherine Burton. First, I'd like to acknowledge Paladin for their ongoing support of the ATI seminar series. And also would like to make a land acknowledgement that the University of Alberta acknowledges that we are located on Treaty 6 territory and respects the histories, languages, and cultures of First Nations, Métis, Inuit, and all First People of Canada, whose presence continues to enrich our vibrant community. So on to Dr. Burton. So Dr. Catherine Burton is a pediatric infectious disease specialist and an assistant professor in the Department of Pediatrics in the Faculty of Medicine and Dentistry at the University of Alberta. She investigates immunization and vaccine preventable childhood disease with a special focus in immunocompromised children. In collaboration with the Special Immunization Clinic and the Canadian Donation and Transplantation Research Program, Dr. Burton is studying the effects of using the live varicella vaccine in children that had solid organ transplants. With the recent authorization of the COVID-19 vaccines for children, Dr. Burton is leading a study at Cellular Children's Hospital investigating the immunogenicity, efficacy, and safety of COVID-19 vaccines in pediatric solid organ transplant recipients. And we're thrilled to hear her discussion on the topic today. So I'll pass it on to Dr. Burton. I'd like to remind you all to please keep your microphones muted throughout the talk. There will be a question period at the end. Thanks.
Thank you very much for that introduction, and thank you for the invitation to speak today, just in virtual presentation fashion. If I can just make sure that people can hear me and can see my slides before I get going, so that I know that I'm actually giving this presentation.
Yes.
Okay, perfect. Thank you. All right. So we're going to talk today a little bit about COVID-19 vaccines in pediatric solid organ transplant recipients. I'm going to give a presentation and an overview of some of the things that I think are important, some of the things that are changing, some of the knowns and some of the unknowns, and I'm hoping to leave a good amount of time at the end so that we'll have time for discussion so that I can answer any questions that anybody might have. I have no relevant disclosures. In terms of objectives, I'm really hoping that at the end of this presentation, everybody in the audience will be able to recognize the importance of a multi-layered approach to protection against COVID-19 in our pediatric solid organ transplant recipients, which of course includes COVID-19 vaccines. You'll be able to discuss some of the knowns and unknowns of COVID-19 vaccines in pediatric solid organ transplant recipients. You'll appreciate the ongoing work at the local and national level to close some of the knowledge gaps around COVID-19 vaccines in pediatric solid organ transplant recipients, and that you'll be able to describe the current recommendations for the use of COVID-19 vaccines in pediatric solid organ transplant recipients. So I feel like this slide may not even be necessary in talks anymore, given how long we have been dealing with this, but just so that everybody is on the same page. So coronavirus disease 2019, or COVID-19, is the illness caused by infection with coronavirus SARS-CoV-2, or severe acute respiratory syndrome coronavirus 2. But what is it really is something that has impacted all of us, led to immense uncertainty and challenges across all aspects of our lives. So looking at COVID in Canada right now, there are obviously extremely high rates of COVID infection all across Canada right now, causing significant strain on our healthcare systems. And COVID is really at the top of a lot of people's minds, I think. If we look, because we're going to be talking about children today, at the age distribution of COVID-19 cases in Canada over the course of the pandemic, you'll see that there are actually relatively large numbers of infections in children here. Now, unfortunately, in children, going from 0 to 19 years of age. Now, while We have all heard that COVID-19 is relatively mild in children, and really, thankfully, it is very mild, given the large numbers of infections. Even a very small proportion of COVID-19 cases in children becoming severe means that we've had thousands of children hospitalized for COVID over the course of the pandemic. And so that certainly is significant. What do we know about which children are getting hospitalized for COVID-19? Well, we're not, unfortunately, very good at predicting which children are more likely to get severe COVID-19 at this point, but we have learned some things. And there have been multiple studies that have identified some underlying health conditions that appear to be associated with more severe COVID-19 disease in children. And these are, of course, important to think about when we're thinking about our prevention strategies that include vaccination. Some of the risk factors that have been identified for more severe COVID-19 in children are obesity, having chronic neurologic conditions, Down syndrome, having chronic lung disease or heart disease, and having multiple medical conditions. Now, I have immunocompromising conditions on here as well, as they do appear to be associated with an increased risk of hospitalization, but the impact of immunocompromising conditions on the severity of COVID-19 remains a little bit unclear. So let's talk a little bit beyond just acute COVID and hospitalization with acute COVID. Children who have been infected with SARS-CoV-2 are also at risk of multi-system inflammatory syndrome in children, otherwise known as MIS-C, which is a relatively uncommon but quite serious condition that can occur many weeks after infection that's likely related to a delayed and dysregulated immune response to the virus. Important to know about this because it really can be quite severe, generally requiring hospitalization, and often actually requiring admission to the intensive care unit. Let's look a little bit about what we know about COVID-19 in our pediatric solid organ transplant recipients. So most infections in our pediatric solid organ transplant population, thankfully, have been mild. However, pediatric solid organ transplant recipients with COVID-19 still do appear to be admitted to hospital more frequently than children without any underlying health conditions. So this overall disease that we see in children with solid organ transplants is in stark contrast to the significant morbidity and mortality that has been seen in adult solid organ transplant recipients with COVID-19. Overall, we've seen similar trends with relatively mild disease in other groups of immunocompromised children also doing relatively well with COVID-19, although some groups, including some children with malignancies, have also had increased hospitalizations. Now, it's difficult to know whether these increased hospitalization is truly due to more severe disease all the time, or whether some of it is related to being more likely to be hospitalized or monitoring due to concerns regarding more severe infection, especially earlier on in the pandemic when we had less experience with COVID-19 in our immune-compromised population. Interestingly, the majority of studies that have looked at hospitalizations with COVID-19 in children that have reported ICU admissions have actually not found that immunocompromising conditions are associated with an increased frequency of intensive care unit admissions with COVID-19. So what are the possible risk factors for severe COVID-19 in our pediatric solid organ transplant recipients? This is important to know, but unfortunately there's limited evidence to really allow us to predict which of these children may be at risk for more severe COVID-19. But based on our experience with other viruses, as well as risk factors for severe COVID-19 identified in children in general, we may expect that children with organ transplants who have a higher level of immune suppression, so for instance, children that are earlier post-transplant or have just recently been treated for rejection, may be at higher risk, as well as children who have other underlying medical conditions that we discussed just previously. And also being unvaccinated may be a risk for more severe COVID-19 in this population, as it would be in any population. So how can we actually protect our pediatric solid organ transplant recipients from COVID-19? So protecting pediatric solid organ transplant recipients from COVID-19 really requires a multi-layered approach that I think is illustrated really nicely in this Swiss cheese model. So as you see here, vaccines certainly are a key layer in this protective strategy, and they have them here as the first layer, but they have holes. And as we'll come to talk about throughout this presentation, it's possible that the holes in the vaccine strategy may be more significant for our immunocompromised patients than they may be for other children, but still definitely very important. Given that there may be greater holes in this vaccine barrier, it certainly is very important for us to continue to use additional protective measures, including use of masks, distancing, hand hygiene, things we're all very familiar with right now, and things like limiting exposure to crowded spaces, especially indoors. So let's move on to talk more specifically about the vaccine, the COVID-19 vaccines. So what COVID-19 vaccines are actually Health Canada approved for children? So for children that are 12 years of age and older, there are 2 vaccines that are licensed for use in Canada. And those would be the Pfizer-BioNTech vaccine, and then the Mrna Spikevax vaccine. And then for the younger children, age 5 to 11, currently there's just the one vaccine that's licensed, and that's the Pfizer-BioNTech vaccine. Now, you'll note here that while the Pfizer vaccine is licensed in both ages, it actually is a different formulation because it's a different dose that is used in the vaccine for the children that are greater than 12 years of age and for the children that are 5 to 11 years of age. Now, just mentioned on this slide is something that we'll talk about a little bit later in the presentation. While both the Pfizer and Mrna vaccines are licensed in children over 12 years of age, the Pfizer vaccine is actually recommended as the preferred vaccine in adolescents, and that is due to a potentially lower risk of an adverse event following immunization of myo or pericarditis, which we will get back to later in the discussion. So both of those vaccines that are licensed are these mRNA COVID-19 vaccines. And I imagine that everybody in the audience probably knows more about vaccines and what kind of vaccine they're getting and specifically how vaccines work than they ever have in the past in the COVID-19 pandemic. But I think that it's still important for people that may not be familiar with it to discuss a little bit about how these vaccines work. And really, it's all about the spike protein. So the spike protein is a protein that's on the surface of SARS-CoV-2, and it's one that the virus uses actually to bind to and enter the cells and cause infection. Now, the mRNA vaccines work by teaching our bodies to recognize that spike protein and ultimately protecting us. So the mRNA is actually the genetic code or a recipe essentially for the spike protein. It's delivered into cells of the immune system, the dendritic cells, and provides the recipe to allow those cells to actually form the spike protein. Those cells then go on to display that spike protein on their surface and stimulate other cells of the immune system to learn to make antibodies that can actually recognize that protein. So if people are exposed to the virus in the future, the body can recognize the spike protein and the antibodies can actually bind to the virus and prevent it ideally from entering and infecting the cells in our body. Now, it's not just all about the antibodies. T-cell immunity is also developed with vaccination, and that also contributes to protective immunity and long-term immunologic memory. T-cells have many different functions. Some of them are vital in helping the B cells to actually be able to produce antibodies, while some can actually be specifically targeted against the virus to actually kill virus-infected cells. Important to know as well that once this mRNA message is delivered from the vaccine, the mRNA is actually very quickly broken down. The recipe doesn't stay in the body, and that mRNA never enters the nucleus of the cell, and the nucleus is where the DNA is. And so it's not possible for these mRNA vaccines to actually affect our DNA. And a spike protein as well that the cells are taught to make is also destroyed by our body shortly after it's made. So let's talk a little bit more about how we determine whether these COVID-19 vaccines work. So when we're talking about how vaccines work, we talk about sometimes vaccine efficacy and vaccine effectiveness. Vaccine efficacy is essentially how a vaccine performs to prevent a predetermined outcome in a controlled trial kind of situation. So like the first large trials that were done with the COVID-19 vaccines in adults and the smaller trials that were subsequently done in children, they had specific endpoints that they looked at in those trials, and then they determined how efficacious the vaccines were at preventing those endpoints or outcomes. So certain outcomes that may be important to look at would be to prevent infection, so prevent all infections, so asymptomatic or symptomatic infection, or perhaps just looking at prevention of symptomatic infection. One could just look at prevention of more severe disease, such as disease requiring hospitalization or intensive care unit transmission, or preventing death. And then you could also do studies that could look at how a vaccine could work to prevent transmission. When we talk about vaccine effectiveness is really how well the vaccine works to prevent a specific outcome in the real world. So this can be assessed at an individual level and at a population level, and it takes many, many other things into account that may not have been taken into account in the controlled efficacy studies. So outlined on the slide here are some of the other factors that can actually affect how well the vaccines work in the real world to prevent whatever the outcome is that we are in fact trying to prevent. So having talked about all of that, what are we hoping to achieve by vaccinating children against COVID-19? Well, ultimately, the focus of vaccination in children is really on protecting the child themselves. So we would ideally like to prevent any and all severe disease, because as I said, even though severe outcomes are rare, with large numbers of infection, we can still have a significant number of children that can have severe disease, and vaccines really are the best way to protect against severe infection. Ideally, we would also hope that our vaccines would prevent the post-COVID infection sequelae in our children, including the multi-system inflammatory syndrome in children. And then something else that we would hope that it would prevent would be post-COVID-19 syndrome or long COVID. So in some people, including children, they can have ongoing or longer duration of symptoms after they have infection with SARS-CoV-2. Ideally, we would like to prevent all infection and prevent transmission, but that may not always be possible. So let's look a little bit at the efficacy of our COVID-19 mRNA vaccines. Now, I know we're supposed to be talking about children and about pediatric solid organ transplant recipients, but really most of what we know about the ability of COVID-19 vaccines to prevent severe disease is based on adult data. And that's because they are able to do large studies in adults to provide information regarding efficacy against severe disease. And this is also partly because severe disease is so much more common in adults. And you have to have a certain number of outcomes to be able to show whether or not your vaccine can actually work at preventing that outcome. So it's much more difficult to study vaccine efficacy against severe COVID-19 in children, as thankfully severe disease is very rare. Now, what you can see from this slide, looking at the efficacy of COVID-19 vaccine in adults against various variants, is that overall in the general adult population, mRNA vaccines provide excellent protection against severe COVID-19 disease. Now you'll notice you don't see the word Omicron on this page, but I promise that we will get to it later. So moving on to what we know about the COVID-19 vaccine and how well it works in children. So there were trials done in children 5 to 11 years of age and children 12 to 15 years of age. And looking first at the trial in children 5 to 11 years of age with the Pfizer vaccine, the efficacy against symptomatic COVID infection was about 90%, but there were only just over 2,000 children in this study, and there really were a very small number of COVID-19 infections. Overall, the study was not initially thought to be powered to actually look at vaccine efficacy. It was really powered to look at the immune response that children would have to infection. So to try to determine how well the COVID-19 vaccines will work in children, we assess the immune responses in children and compare them to the immune responses seen in adults, where we do actually have that efficacy data. And in this study, in the children who had their immune responses studied, they found that the humoral or the antibody immune responses were very similar and non-inferior to the responses seen in young adults. There were additional children that were added as an additional safety cohort to this study, and those children were actually added when the signal for myocarditis being an adverse event after immunization in the adolescent age group. The safety cohort was added at that point. We'll discuss a little bit later about those adverse events, but essentially there were no serious adverse events and no cases of myocarditis or pericarditis that were identified in this trial. Looking at the similarly performed study in the 12 to 15 year age group, about the same number of children, but in this case, half of them got vaccine and half got placebo, whereas in the younger age group, 2/3 of them got vaccine. And I'm sorry, I should have mentioned in both of these trials, children with immunocompromising conditions were excluded. Also good vaccine efficacy against symptomatic COVID-19 disease, which was the same with the other trial, and then good immunogenicity also with similar antibody immune responses to what was seen in young adults. What do we know about immune responses to COVID-19 vaccines in pediatric solid organ transplant recipients? So not a lot overall, but there are a few small studies that have provided us with some useful information. And most of these studies looked at basically whether or not pediatric solid organ transplant patients had a detectable or a positive antibody response after receiving a 2-dose series of mRNA COVID-19 vaccine. Looking at all of these studies together, the range was between 52 and 74% of pediatric solid organ transplant recipients that actually had a detectable antibody response after having 2 doses of a vaccine. While these responses are not ideal, they're generally more robust than what has been reported in our adult solid organ transplant recipients, suggesting that children respond better than adults with solid organ transplants. Some issues with all of these studies is that there is no clear correlate of protection for antibodies in terms of actually protecting against disease, especially with emerging variants. There are also no studies of effectiveness of COVID-19 vaccines in pediatric solid organ transplant recipients, nor has there been evaluation of the other parts of the immune system. So looking at the cell-mediated responses to the vaccine in pediatric solid organ transplant recipients. Also, all of these studies were only in children that were 12 years of age and older, as the vaccine was only more recently introduced in the younger population. Something else to take away from these studies are the factors that were identified as being associated with a lack of response to vaccine. So many of these are not surprising and are correlated with more intense immune suppression. So factors that were associated with a lack of response to vaccine included earlier time post-transplant, use of multiple immunosuppressive agents, use of anti-metabolite immune suppression, recent use of rituximab, and in one study found that neutropenia was associated with lack of vaccine response. So as I mentioned before, immune responses to COVID-19 vaccine is more than just antibodies, and T-cell immune responses are likely important in the protection against severe COVID. And what we know from looking at T-cell immune responses in adult solid organ transplant recipients is that overall their responses are less robust compared to control. However, T-cell responses are often present even when you don't have a detectable antibody response, suggesting that assessing only antibodies may actually underestimate vaccine immunogenicity in this population. So given the relatively poor immune responses seen in adult solid organ transplant recipients and the significant morbidity and mortality from COVID-19, studies were done very early to evaluate the immunogenicity of a third dose of COVID-19 vaccine in adult solid organ transplant recipients. And these studies did demonstrate improvement in both the antibody and T-cell responses with a 3-dose versus a 2-dose primary series of vaccine in adult solid organ transplant recipients. And importantly, the safety profile was similar to using a 2-dose series. Now, we don't have any data regarding really the use of 3-dose series in pediatric solid organ transplant recipients, but studies are ongoing. Just one thing that I think is useful to clarify when we're thinking about numbers of doses, and we hear people talking about third doses and booster doses and those kinds of things. So when we're talking about our immunocompromised population and we're talking about third doses, we're really talking about a third dose or a 3-dose primary series in these immunocompromised individuals to help establish a strong initial response to the vaccine. So they may not respond well to the first 2 doses of vaccine as somebody who is not on immune suppressing medications. So they may need that additional dose of vaccine to initially get to a stronger response from the vaccine. This is different than what is generally referred to as kind of booster doses in the general population, where people may be receiving their third dose, but they're given that dose as a booster dose later on after they've had their initial 2 doses, because we've seen that vaccine immune responses decrease over time. And so this booster is actually to try to boost the protection back up to the higher level that was initially achieved with the primary series. Okay, I'll talk a little bit about vaccines versus Omicron. So Omicron, we know that there is marked antigenic drift in the Omicron variant. There are many changes in the SARS-CoV-2 spike protein, so it looks very different to our immune system. And unfortunately, it can escape neutralizing antibody responses, leading to many more breakthrough infections after vaccination. What we're learning is that booster doses of vaccine can increase the levels of the SARS-CoV-2 antibodies, including those that can neutralize Omicron. And we also know, are finding out that the T-cell responses from vaccination appear to remain quite strong against Omicron. They appear to be much less affected than the antibody response, and this is likely important to maintain protection against severe disease. So there's some very recent preliminary real-world evidence from adults in the United Kingdom, which suggests that vaccination does provide protection against more severe disease from Omicron, especially earlier after 2 doses of vaccine or after a 3rd dose of vaccine. Although we don't know how long that protection will last. Similarly, some very recent data from the United States also supports good vaccine effectiveness for the Mrna vaccines against COVID-19 associated hospitalizations with Omicron in adults, with vaccine efficacy of about 81% in the first 6 months after receiving your 2nd dose of an Mrna vaccine. This then decreases to about 57% if you've had your 2nd dose greater than 6 months before, and then increases to 90% after the 3rd or the booster dose. So some good news. Also, good news for children is that there is early evidence to suggest that, as we had hoped, that COVID-19 vaccination does appear to protect against multi-system inflammatory syndrome in children, which, as we mentioned, can be a very severe complication of COVID-19 and certainly would be one of the goals of immunizing our children, would be to protect against this severe complication. Moving on to the safety of COVID-19 vaccines. Generally, the COVID-19 vaccines are well tolerated in children with side effects including fatigue, headache, muscle pains, fevers, joint pains, pain at the injection site. And the safety profile in solid organ transplant recipients appears to be similar to that seen in non-solid organ transplant recipients, with no clear evidence of an association with rejection. There have been reported cases, or has certainly been a signal of myocarditis and pericarditis reported following vaccination with COVID-19 mRNA vaccines. And the risk of myocarditis and pericarditis following vaccine is highest in adolescent and young adult males, with an estimated incidence of less than 10 per 100,000 people after the second dose of the vaccine. Evidence suggests that the risk of myocarditis or pericarditis after a vaccine is higher with the Mrna vaccine, and this is why the Pfizer vaccine has been recommended as the ideal vaccine for adolescents 12 years of age and older. The risk may also be lower with a longer time interval between the first and the second dose of vaccine. And very important, and a question I know a lot of people have had, is what will the risk of myocarditis and pericarditis be in the 5 to 11 year age group? And we now have some data from the US where many children have already received 2 doses of vaccine to show that the risk of myocarditis, pericarditis in this age group appears to be exceedingly rare, with a reported rate of approximately 4 per million doses of vaccine administered. So that's good news. Also reassuring that most cases of myo or pericarditis following vaccine have been relatively mild and have had complete recovery. When we're talking about myocarditis, pericarditis following vaccine, we of course need to balance the risks of that against the risks of COVID-19 infection, including the risk of myocarditis from COVID-19 infection. There have been multiple studies that would suggest that the risk of myocarditis from COVID-19 infection is as high or higher than the risk from the vaccine. And of course, there are many other risks with COVID infection that we have discussed. What is very important, certainly, is to make sure that we educate children and families about the symptoms that could suggest myocarditis or pericarditis, and the importance of seeking medical attention if they were to have symptoms like chest pain, shortness of breath, or palpitations. And these generally do occur relatively early after vaccine, usually within a week after vaccination. Just talking a little bit more about monitoring for adverse events following immunization. So an AFI, or an adverse event following immunization, really is any untoward medical occurrence which follows immunization, which does not necessarily have a causal relationship with usage of the vaccine. So AFI should always be reported if there's a temporal relationship with the vaccine, there's no other clear cause for the event, and if it's unexpected or severe. So there are excellent both passive and active surveillance systems for AFIs in Canada, and there's mandatory reporting for healthcare professionals for AFIs in most provinces and territories. We're very lucky in Canada also to have active surveillance through the Immunization Monitoring Program Active at 12 pediatric hospitals across Canada. And this is active surveillance both for AFIs and for vaccine preventable diseases. And this involves nurse monitors and pediatric infectious disease investigators at each center actually actively monitoring emergency room visits and admissions for adverse events following immunization, as well as vaccine preventable diseases. So There are many vaccine-related networks in Canada that have come together to improve the identification and response to adverse events people may experience following COVID-19 vaccination. And one of these that I wanted to highlight is the Special Immunization Clinic Network. So there are 17 special immunization clinics across 10 provinces. I lead the Special Immunization Clinic in Edmonton. And we see patients who have had challenging adverse events following immunization and patients who have underlying medical conditions that may affect their response to immunizations. The Special Immunization Clinic Network is a unique network that supports public health and in managing patients with unexpected severe and serious APs and determining the safety of administering further doses of vaccines. The network also works to develop standardized evaluations and management of pediatric patients that have APHIs following vaccination. And this network has been especially important with the widespread immunization with new vaccines in the COVID-19 pandemic. The SIC network has also been wonderful in terms of being able to support multi-center studies, including multiple COVID-19 vaccine-related studies. So what else are we doing to help to close the knowledge gaps around COVID-19 vaccines in pediatric solid organ transplant recipients locally and nationally? So while we have learned a great deal in a very short time frame about the use of COVID-19 vaccines in solid organ transplant recipients, there's still a lot to be learned. So it was very clear early on in COVID-19 vaccine development that there were going to be significant knowledge gaps with respect to COVID-19 vaccination in solid organ transplant recipients, and especially pediatric solid organ transplant recipients. With the support of the Canadian Donation and Transplantation Research Program, the Special Immunization Clinic Network, and a team of researchers across the country led by Dr. Dipali Kumar in Toronto, we were successful in receiving funding from the Canadian Immunity Task Force to support a national Canadian research study to investigate the safety and immunogenicity of COVID-19 vaccines in adult and pediatric transplant recipients. Dr. Sneha Suresh, pediatric immunologist here at the University of Alberta, and I are leading the pediatric arm of the study and collaborating with pediatric infectious diseases physicians and transplant physicians in Vancouver and Toronto, as well as with the adult investigators. Dr. Dima Kabani, an adult transplant infectious diseases physician at the University of Alberta, is leading the adult arm of the study in Edmonton. So in this study, we are looking at the antibody or humoral as well as the cell-mediated immune responses to COVID-19 vaccines in 50 pediatric solid organ transplant recipients, as well as age-matched healthy controls. And we're looking at their responses prior to and after each dose of COVID-19 vaccines, as well as later on at 6 and 12 months after their first dose. We're also actively doing surveillance for any adverse events after immunization using a combination of telephone calls as well as chart review. And we really hope that the results of the study will help to inform COVID-19 vaccine recommendations in pediatric solid organ transplant recipients and provide critical early safety data regarding the use of COVID-19 vaccines in pediatric transplant recipients. We so far have enrolled over 20 solid organ transplant recipients in Edmonton, as well as controls, and we're still enrolling solid organ transplant recipients and controls. So moving on finally to talk about the actual COVID-19 vaccine recommendations for pediatric solid organ transplant recipients. So it made me laugh yesterday. You can't prepare a talk about COVID without updating your search very, very close to the time that you're giving your talk, because just yesterday afternoon, the National Advisory Committee on Immunization came out with updated recommendations on the usage of COVID-19 vaccines in children 5 to 11 years of age, with specific new recommendations for immunocompromised children. So as of yesterday, pediatric solid organ transplant recipients 5 to 11 years of age are recommended by the national body to receive a 3-dose series of the Pfizer COVID-19 vaccine using the pediatric dosage. Prior to yesterday, the recommendation had been to receive a 2-dose series. We don't yet know what Alberta we'll decide about that, but that is the current national recommendation. The recommendation is the same for solid organ transplant recipients greater than 12 years of age to receive a 3-dose series of the Pfizer vaccine using the higher dose that's recommended for their age. In terms of timing, in terms of the optimal interval between the doses, this has been a topic that has been hotly debated. The National Advisory Committee on Immunization initially had recommended an interval of 8 weeks between the first and second dose of COVID-19 vaccine. Because there was evidence that having a longer duration between the 2 doses of vaccine may induce a more robust and longer lasting immune response, may have been associated with a lower risk of myocarditis. However, a shorter interval may be more appropriate when the benefits of earlier protection are thought to outweigh the benefits of more durable protection in populations that may be at higher risk of more severe COVID or who may respond less in a less robust manner to the vaccine, like our pediatric solid organ transplant recipients. NACI is now recommending an interval of between 4 and 8 weeks for immunocompromised children. The decision about the optimal interval would need to really take into account the risk of the patient getting infected with SARS-CoV-2 and the likelihood that they may develop more severe disease. The recommendation that children who've had solid organ transplants should receive COVID-19 is strongly supported by the Canadian Society of Transplantation, as well as by US transplant societies, including the American Society of Transplantation and the International Society of Heart and Lung Transplantation. Just briefly to touch a little bit on the principles of immunization in our solid organ transplant candidates and recipients. We always want to try to immunize when the best response is anticipated. So usually this is pre-transplant, if we can, early in the course of disease, and generally at least 2 weeks before transplant, so that patients could have the best possible vaccine response. Post-transplant, we always have to balance earlier protection versus a possibly stronger response later. As we saw in the early slides, that children appear to be less likely to develop an antibody response to the vaccine if they were immunized earlier after transplant. And another thing that I always want to talk about when we're talking about immunization in solid organ transplant candidates is to consider the patient environment and always try to protect our patients by protecting those around them. So immunizing family members, close contacts, healthcare workers. In terms of the timing of administration of COVID vaccines in pediatric solid organ transplant recipients, so ideally we would give them the vaccine before transplant, at least 2 weeks. If they're getting it after transplant, waiting at least a month after transplant, or after treatment of acute rejection. And certainly if they have received rituximab, which will significantly impact their ability to respond to vaccine, we would wait at least 3 months after rituximab. If a patient has had previous COVID-19, it is prudent to wait until symptoms have resolved and that they're no longer considered infectious before getting the COVID-19 vaccine. So just finishing up with some potential future directions. So I'm hoping that perhaps the next time, maybe not the next time, but sometime in the future when I'm going to be giving a similar talk, we'll know a lot more about the efficacy and effectiveness of COVID-19 vaccines in pediatric solid organ transplant recipients, as well as know more about the duration of protection. I hope that we'll be able to learn how best to optimize vaccine responses in pediatric solid organ transplant recipients. What's the ideal spacing of doses? What's the ideal number of doses? Will we be considering new vaccine formulations that work in different ways, or perhaps mixed vaccine schedules to stimulate the immune system in different ways? We may be discussing COVID-19 vaccines for children under 5, and this may actually be coming relatively soon for the Pfizer and Mrna mRNA vaccines. Perhaps at some point in the future, we'll even be talking about universal coronavirus vaccines that can protect against SARS-CoV-2, as well as other potential animal-derived coronaviruses that could cause outbreaks or pandemics in the future. With that, I'd just like to acknowledge, there are many, many people to acknowledge. So I've actually just decided to acknowledge large groups and bodies and funding agencies that have really been very important in helping us to do the work that we're doing in advancing the knowledge around COVID-19 vaccines in pediatric solid organ transplant recipients. So I'd like to thank everybody, and I'd like to thank everyone for listening and take questions.
Thank you, Dr. Burton. That was a fantastic talk and incredibly informative. And there's definitely some questions in the chat box, but like any good moderator, I'll selfishly ask my own question first, of which I have a few, but I'll only ask one for now. So more times than I would have anticipated, I've had 11-and-a-half-year-old patients or parents of 11-and-a-half-year-olds ask me if they should wait until their child is 12. And I always say, no, you should take the vaccine, but it has gotten me thinking, especially in the solid organ transplant population, is the 30 microgram dose incrementally more important in an immunocompromised population compared to a 10 microgram dose? And this may be just like a hypothetical question in terms of anticipated antibody response in somebody that may or is already at risk of having a suboptimal antibody response.
Yeah, that's a fantastic question, and one that we don't necessarily know the answer to. And I totally agree with your with what you have been advising in terms of, you know, getting the vaccine that's available to them. In terms of, you know, why we're using the doses that we're using in the ages that we're using them, that was really based on the studies trying to find the dose that was able to elicit a strong immune response with the least side effects possible, right? Because that was the goal for the immunization. Now, of course, that was not done in an immunocompromised population. And so that may not carry over to our immunocompromised populations. And perhaps as we learn more, perhaps using a different dose, as we do with some other vaccines already in our pediatric solid organ transplant recipients, using a higher dose may actually be something that turns out to be a reasonable strategy. There is some evidence in adults when you look at the Pfizer vaccine and the Mrna vaccine, while not, you know, directly comparable, the Mrna vaccine does have a higher dose of, you know, antigen essentially that not antigen, but that it uses, and there is some evidence to suggest that immunocompromised patients do have a more robust response to that, but that may also come with more side effects and that kind of thing. So ultimately, there's no, you know, clear right answer right now, but that definitely is something that you know, may be explored. But we still have to get to that first step of actually finding out, you know, how well do our patients even respond to these vaccines, right? Because we clearly can't just extrapolate from adults' data to our children. And that's why it's so critical to determine how they're actually responding to these vaccines before we can start to develop these strategies to kind of optimize their response.
Great. Dr. Masood, Andrew Masood, you had posted a lengthy two-part question. I wonder if you want to unmute yourself and perhaps ask the question yourself.
Oh, thanks, Michael. It was like a point of interest. First of all, thanks for the great talk. It's influential for sure. It's a very sensitive material, identifying the pediatric vaccination, the number of doses, the outcomes, especially in the immunocompromised population of pediatrics or pediatrics themselves, even without any comorbidities. So my question is, first, for the cytomegalovirus, we know that it's impacting the long-term outcomes for solid organ transplantation. Do you think that would it be feasible combining both the cytomegalovirus vaccination with the proposed and tested COVID-19 pediatric vaccination for solid organ transplant patients? So that would be a feasible approach as a standard of care. My second question, which stems from this point, would COVID vaccination as an mRNA vaccine shape the host immunity so that it can withstand future CMVs or cytomegalovirus? Do you think there's a correlation between the two? And thank you so much.
Great. Those are very interesting questions, and CMV is certainly an area of interest for me. In terms of your first question, we don't have, an established CMV vaccine at this point. So I'm not sure. Are you asking about like whether we would use the same vaccine technology, or?
I think maybe I built this question from data from the US, not Canada specific, but there's some studies about the CMV vaccine and its efficacy, especially in pediatric population. So I thought, would it be feasible connecting the two or studying if there are any synergistic effect between the two vaccines, if any, in Canada, or can be this a new standard of care, or it's like out of curiosity. It's more of a point for discussion rather than a question for your presentation. And thank you so much.
Yeah, absolutely. I mean, very, very interesting. And I can't say that I'm, I didn't specifically review the CMV vaccine data prior to this. I'm not sure that I have a lot to add to that, but certainly there would, be significant benefits if we did have an effective CMV vaccine in our pediatric solid organ transplant recipients, given the numbers of our pediatric recipients who are CMV seronegative at the time of transplant and go on to receive a CMV seropositive organ. And I don't know, I'm not actually familiar with evidence to suggest that the mRNA COVID-19 vaccines provide any protection against CMV in the future. I mean, there certainly is some suggestion that any kind of vaccines, by stimulating the immune system, may elicit some kind of cross protection to other things. But very interesting questions about CMV.
Thank you so much. Thank you. So far, what we know from the literature, that CMV deemed essential to potentiate the COVID infection. So this could be a good starting point. We can follow up on this with the vaccination efficiency, if there will be a potential synergistic effect or maybe opposition between the two vaccines. But I thank you for your talk, and hopefully we look forward toward something like that in your research. Thank you so much.
Thank you.
Thanks, Dr. Masood. So Dr. Prixadis, I apologize if I pronounced this incorrectly, asks, would you comment on anti-N responses in pediatric solid organ transplants in order to detect asymptomatic infection? How reliable is this marker in studying vaccine effectiveness against infection in this population?
Sorry, that's a great question, Yuta. Thank you for the great question. So you're asking about and you can feel free to unmute so that we can discuss this, but you're asking about the anti-N responses. So we know the anti-nucleocapsid responses to actual infection don't appear to be as reliable markers of infection in children, right? So you're asking about it as a marker for vaccines or as a marker of prior infection?
For vaccine efficacy, I mean, could you model vaccine efficacy even if it's not a reliable marker of asymptomatic infection in pediatrics, just by estimating its sensitivity?
Yeah, I mean, I think that that's a very interesting question. And I think that, it's certainly maybe possible to do something like that. I'd have to look. I know that I haven't seen all of the data out of the Canadian study or Alberta-based study that had some data on the anti-N responses in children, but that would be something really interesting to look at.
And then so I'll ask another question unless other questions come up. But one of my, it seems that at least there doesn't appear to be a signal that the risk of post-vaccine myocarditis or post-infection MISC is higher in the solid organ transplant population. In fact, maybe it's even lower. But of course, you need a massive power to be able to study this because the events themselves are quite rare as it is, and there's only so many solid organ transplant recipients. But could you comment on the theoretical risk in the solid organ transplant population for both the vaccine-associated adverse effects and MIS-C, and whether or not there's sort of like a plausibility as to why the risk might be different?
Yeah, I mean, that's a fantastic question. And to be able to really answer that question, we would have to actually understand a lot more about the mechanisms behind these things, the mechanism behind the vaccine-associated myocarditis, for instance, which is not well understood, but, may be immune-related. And certainly, MIS-C is thought to be an immune-related phenomenon, as are a lot of things actually with COVID-19 infection. And so I think it's very plausible that our patients who are immune suppressed, because we are immune suppressing them for other reasons, may actually be at lower risk of some of those outcomes. So I'm only aware of, and it could certainly be wrong, I'm only aware of one reported case of MIS-C in a pediatric transplant recipient, but I'm not sure if you're aware of more. I'm not aware of any cases of vaccine-associated myocarditis or pericarditis in transplant recipients. But as you say, even in the highest risk, population, that's still a very rare outcome. So I wouldn't expect to see those kinds of signals. But yeah, I think that it's very plausible that based on their immune suppression, they may be protected. And, some people hypothesize that actually, one of the reasons that immunocompromised children, who we generally think are at higher risk of having, more severe infections and that kind of thing, have had relatively mild courses overall with COVID-19, is that a lot of the kind of morbidity and severity associated with COVID-19 is actually not perhaps related directly to the viral replication, but to the immune response to the virus. So, perhaps there is some protection offered there.
Wonderful. I see that a question came up from Andrew Mason. If you want to ask your question, maybe we'll wrap up with that given the time.
Hi, Catherine. That was very nice presentation. How are you doing your cell-mediated immune assays? Are you using the QIAGEN quantiferon kit? Have you got your roll your own, or and are you working with someone else, or how are you doing all that?
Yeah, so absolutely. So Dr. Dipali Kumar in Toronto, it's actually her lab that's going to be doing the CMI assays. And they're going to be done by flow, as far as I'm aware. But we haven't actually shipped any samples. None of that has even been done yet. So I think that they're going to start with some of the adult samples and make sure that they have the methodology that they want before we decide exactly what's going to be done with the precious pediatric samples. But that's my understanding of what's going to happen. But they're all being done in one centralized, in her centralized lab there, so that the responses will all be comparable, because they'll be coming from multiple different institutions and a relatively small number of patients, only 100 pediatric patients in total.
Right. Well, that's going to be a bit tricky with flow, right? You need a few cells. And that's why I was asking, because if you had an interest in doing a quick look and see here, the QIAGEN and BioNTech have got together, and they've got an assay based on the Mrna mapping of COVID peptides, where you can just do a straightforward quantiferon assay if you are inclined, or rather if you've got $5,000 to buy the kit. So it costs, I think it costs about $50 a go, but certainly Greg Terrell's set up to do the quantiferon assay. So, and this is also a much smaller amount of blood that you need, which is
Yeah, so that would be potentially more of an issue if we had the even younger children that were eligible for a vaccine, because we've been able to get a reasonable amount of blood and isolate enough PBMCs to have enough cells to do the flow. But certainly that's great to know that, and something to consider if we are looking at the younger age groups where collecting 15 mils of blood just isn't an option.
Yeah.
Perhaps we'll close here. There's a lot of really interesting discussion. In speaking on behalf of Dr. Burton, I'm sure she'd be happy to take any and all questions, because she always takes all of my questions. So next week's ATI seminar, we're pleased to have Dr. Amanda Van Bynum presenting family experiences with non-therapeutic research on dying patients in the intensive care unit. And also a reminder to you all that the CDTRP has launched the Research Innovation Grant Program for 2022 with support from Paladin. The ATI is delighted to offer 3 additional awards specifically for Alberta-based research teams. So that's fantastic. And the link for the application is provided now in the chat box. So thank you very much again. And thank you, Dr. Burton, for a fantastic talk.